Good afternoon, student. Let's learn about inflammatory bowel disease topic today. So, what is inflammatory bowel disease? So, the term inflammatory bowel disease is reserved for condition characterized by presence of idiopathic, that is unknown cause, idiopathic intestinal inflammation. Idiopathic intestinal inflammation, ulcerative colitis, or Crohn's disease. Although the availability of population genetics and molecular biology has contributed to our understanding of pathogenesis of inflammatory bowel disease, the etiology remains unclear. So, what is ulcerative colitis? Ulcerative colitis is a disease of rectum and colon with extraintestinal manifestation. The incidence is 10 per 1 lakh per year in UK, with a prevalence of 160 per 1 lakh population. Ulcerative colitis affects men and women equally in early life. Although it is said to be more common in male in later life. It is most commonly diagnosed between age of 20 and 40 years. Most commonly diagnosed between age of 20 and 40 years. Ulcerative colitis is far more common in the United States and Western Europe, but relatively rare in Far East and Tropic. Asians who spent their childhood before the age of 14 in Asia have a much lower incidence of ulcerative colitis than Asian born and raised in UK, suggesting an important effect of environmental exposure in childhood. So, what is etiology? Etiology, cause of ulcerative colitis is unknown. Nobody would know. There is clearly a genetic contribution, as 10 to 20% of patients have first degree relative with inflammatory bowel disease. Patients with severe colitis have a reduction in number of anaerobic bacteria. Patients with severe colitis have a reduction in number of anaerobic bacteria and in the variability of bacterial strain in the colon, but no causative link with any specific organism has been identified. Unlike Crohn's disease, smoking seems to have a protective effect in ulcerative colitis. Unlike Crohn's disease, smoking seems to have protective effect in ulcerative colitis and has been the basis of therapeutic trial of nicotine. Relapses are occasionally said to be associated with period of stress. But personality and psychiatric profile in patients with ulcerative colitis are the same as those of normal population. So, what is pathology here? Pathology in virtually all cases, the disease starts in the rectum and extends proximally in continuity. Colonic inflammation is diffuse, confluent, and superficial, primarily affecting the mucosa and superficial submucosa. What is pseudopolyp? Pseudopolyposis occurs in almost one quarter of cases. Pseudopolyposis occurs. Structure in ulcerative colitis is very unusual, not usual, very unusual. Unlike Crohn's disease, should prompt urgent assessment because of the possibility of coexisting carcinoma. A small proportion of patients develop irregular irregular mucosal swelling, dysplasia associated lesion or mass, which are highly predictive of coexisting carcinoma. Histopathological examination reveals an increase in inflammatory cell in the lamina propria and crypts of liver cone, and there are crypt abscess. There is depletion of goblet cell mucin. With time, pre-cancerous change can develop dysplasia. High-grade dysplasia is regarded as an indication for surgery, as 40% of colectomy specimen in which high-grade dysplasia was detected will have evidence of a colorectal cancer. In contrast, optimum management of low-grade dysplasia is currently controversial. 10 to 20% of patients with low-grade dysplasia will have a cancer at colectomy. Progression rate of low-grade dysplasia to invasive cancer is unclear, and many cancers in patients with low-grade dysplasia probably develop without high-grade dysplasia. So what is symptom? Clinical presentation depend in large part on extent of disease. If confined to rectum proctitis, there is usually no systemic upset and extra-alimentary manifestations are rare. The main symptoms are rectal bleeding, tenesmus, and mucus discharge. The disease remains confined to the rectum in 90% of cases, but proctitis may extend proximally. Colitis is almost always associated with bloody diarrhea and urgency. Severe and/or extensive colitis may result in anemia. Severe and/or extensive colitis may result in anemia, hypoproteinemia, and electrolyte disbalance. Pain is unusual. Children with poorly controlled colitis may have impaired growth. More extensive the disease, more likely extraintestinal manifestations are to occur. Extensive colitis is also associated with systemic illness characterized by malaise, loss of appetite, and fever. Classification of colitis severity. The assessment of severity of ulcerative colitis is determined by frequency of bowel action and the presence of systemic sign of illness. Mild disease is characterized by fewer than 4 stools daily with or without bleeding. There are no systemic sign of toxicity. Moderate disease corresponds to more than 4 stools daily but with few signs of systemic illness. There may be mild anemia, abdominal pain may occur, inflammatory marker including erythrocyte sedimentation rate and CRP, C-reactive protein are often raised. Severe disease corresponds to more than 6 bloody stools a day and evidence of systemic illness with fever, tachycardia, anemia, raised inflammatory marker. Hypoalbuminemia is a common and ominous finding. Fulminant disease is associated with more than 10 bowel movement per day, daily, fever, tachycardia, continuous bleeding, anemia, hypoalbuminemia, abdominal tenderness, and distension, the need for blood transfusion, and in most severe progressive colonic dilatation, toxic megacolon. This is a very significant finding suggestive of disintegrative colitis and an indication for emergency surgery if colonic perforation is to be avoided. Extraintestinal manifestations, arthritis in around 15% of patients, and typically large joint polyarthropathy affect knee, ankle, elbow, wrist. Sacroiliitis, ankylosing spondylitis are 20 times more common in patients with ulcerative colitis than the general population and are associated with HLA-B27 genotype. Sclerosing cholangitis is associated with ulcerative colitis. can progress to cirrhosis and hepatocellular failure. Patients with ulcerative colitis and sclerosing cholangitis are also at significantly greater risk of development of large bowel cancer. Cholangiocarcinoma is an extremely rare association and its frequency is not influenced by colectomy. The skin lesion, erythema nodosum, and pyoderma gangrenosum are associated with ulcerative colitis and both normally resolve with good colitis control. The eye can also be affected by uveitis and EP scleritis. Acute colitis. Approximately 5% of patients present with severe acute fulminant colitis. Intensive medical treatment lead to remission in 70%, but the remainder require urgent surgery. Toxic dilatation should be suspected in patients who develop severe abdominal pain and confirmed by presence of a plain abdominal radiograph of a colon with diameter of more than 6 cm. A reduction in stool frequency is not always sign of improvement in patients with severe ulcerative colitis. And falling stool frequency, abdominal distension and abdominal pain resulting from progression of inflammatory process through the colonic wall are strongly suggestive of disintegrative colitis and impending perforation. Plain abdominal radiographs should be obtained daily in patients with severe colitis. Progressive increase in colon diameter despite medical therapy is an indication for urgent surgery. Colonic perforation is a grave complication with a mortality rate of 40%. Steroid may mask physical signs. Severe hemorrhage is uncommon, 1 to 2%, but may occasionally require urgent surgical intervention. Cancer risk in colitis. Risk of cancer in ulcerative colitis increases with duration of disease. At 10 years from diagnosis, it is approximately 1%, increasing to 10 to 15% at 20 years and 20% at 30 years. Patients with pancolitis, defined as presence of inflammation proximal to splenic flexure of more than 10 years duration, should be entered into a screening program in order to detect clinically silent dysplasia, which is predictive of increased cancer risk. The value of a screening program remains somewhat controversial. However, with most ulcerative colitis patients who develop cancer, approximately 3.5% of all patients presenting with their tumor in between attendances for screening colonoscopy, carcinoma is more likely to occur if the whole colon is involved or if the disease started early in life. Malignant change, often atypical and high grade, may occur at any site at once. Colonoscopic supervision with dye spray, chromoendoscopy, or multiple biopsy every 10 cm is undertaken to look for subtle mucosal abnormality which can occur in flat mucosa or DALM. Investigation, endoscopy and biopsy. Rigid, flexible sigmoidoscopy can detect proctitis in the clinic. The mucosa is hyperemia and bleed on touch, and there fulminating ulcerative colitis with toxic dilatation of transverse colon. Resection specimen from patients with long-standing ulcerative colitis showing narrow tubular colon with area of cancerous change in the rectum and sigmoid. May be a purulent exudate where there has been remission and relapse. There may be a regenerative mucosal nodule or pseudopolyp. Later, tiny ulcer may be seen that appear to coalesce. Colonoscopy and biopsy has a key role in diagnosis and management. First, to establish the extent of inflammation, although colonoscopy is contraindicated in severe acute colitis because of the risk of colonic perforation. To distinguish between ulcerative colitis and Crohn's colitis, although this can be exceptionally difficult. Table 70.2. The monitor the response to treatment to assess long-standing case for malignant change. Radiology. A plain abdominal film may indicate the severity of disease in acute setting and is particularly valuable in demonstrating the development of toxic megacolon. Variant in enema has largely been replaced by CT, although a contrast study will distinguishing ulcerative colitis and Crohn's disease. Ulcerative colitis, Crohn's disease. So macroscopic distribution colon and rectum. Crohn's disease anywhere in the gastrointestinal tract. Rectum always involved, often spared in Crohn's disease. Perianal disease rare in ulcerative colitis. Fistula formation rare in ulcerative colitis. Stricture is also rare. Perianal disease common in Crohn's disease. Fistula formation common in Crohn's disease. Stricture formation common in Crohn's disease. Microscopic layers involve mucosa and submucosa involved in ulcerative colitis. Full thickness involved in Crohn's disease. Granuloma no. Fissuring no. Crypt abscess common. Crypt abscess common in ulcerative colitis. Granuloma common in Crohn's disease. Fissuring common in Crohn's disease. Crypt abscess rare. Full thickness involved in Crohn's disease. So, what is the line? Variant in enema has largely been replaced by CT, although a contrast study will show featureless colon. CT finding in pancolitis may show significant thickening of the colonic wall as well as inflammatory stranding in the colonic mesentery. Bacteriology. A stool specimen should be sent for microbiological analysis when ulcerative colitis is suspected in order to exclude infective colitide, notably Campylobacter, which may be very difficult to distinguish from acute severe ulcerative colitis. Clostridium difficile colitis may needed to be considered in population at risk of this disease. Treatment. Effective treatment of ulcerative colitis require a multidisciplinary approach to management. This involves gastroenterologist, nurse, nutritionist, enterostomal therapist, occasionally clinical psychologist and social worker as well as surgeon. Principle of management of ulcerative colitis. Many patients can be adequately maintained for years on medical therapy. Toxic dilatation must be suspected in any colitis patients who develop severe abdominal pain. Missed colonic perforation is associated with high mortality. Colitis patients are at increased risk of developing cancer. Those with pancolitis of long duration are most at risk. Medical treatment. Medical therapy is based on anti-inflammatory agent. The 5-aminosalicylic acid 5-ASA derivative can be given topically, per rectum or systemically. They act as inhibitor of cyclooxygenase enzyme system and are formulated to protect aspirin-related drug from degradation before reaching the colon. They can be used long-term as maintenance therapy. Computer tomography scan demonstrating colitis with thickened colonic wall and inflammatory stranding in the mesentery. Corticosteroids are the mainstay of treatment for flare-up, either topically or systemically, and have a widespread anti-inflammatory action. Immunosuppressive drug azathioprine, cyclosporine can be used to maintain remission and as steroid-sparing agent. The monoclonal antibodies infliximab, adalimumab, both act against anti-tumor necrosis factor alpha, which has a central role in inflammatory cascade. Most recently, vedolizumab, which block integrin, has been used as rescue therapy for severe colitis to try and avoid emergency colectomy. Acute colitis. Patients with mild attack usually respond to a course of oral prednisolone. A moderate attack often responds to oral prednisolone, twice daily steroid enema, and 5 ASA. Failure to achieve remission as an outpatient is an indication for admission. Severe attack of ulcerative colitis occurs in up to 10% of patients and are emergency requiring hospital admission. A regular assessment of vital sign, weight, and the abdomen is required. A stool chart should be kept and plain abdominal radiography is taken daily and inspected for dilatation of transverse colon. Presence of mucosal island or intramural gas on plain radiograph, increasing colonic diameter, or a sudden increase in pulse and temperature may indicate a colonic perforation. Fluid and electrolyte balance is maintained. Anemia corrected, adequate nutrition is provided, sometimes intravenously in severe cases. A patient is treated with intravenous hydrocortisone 4 times daily as well as rectal steroid. If there is failure to gain an improvement within 48 hours of commencing high dose intravenous steroid, then surgery should be considered, and it is certainly advisable if there has been no improvement within 3 to 5 days. Regular and joint review by gastroenterologist and surgeon is essential to identify patients who are failing to make anticipated progress and to ensure that surgery is neither inappropriately delayed nor undertaken. Gastroenterologist will use azathioprine, cyclosporine, and infliximab in severe acute attack to attempt to include remission.